All right, everybody. Hello and welcome to. All right, everybody. Hello and welcome to another edition of Inside the Training Room here with Dr. Dana Pisacki, who is going to talk to us this week about shoulder injuries. Doctor, welcome to the show.
Thanks for having me, Mike. It's great to be back.
All right. First of all, we think a lot about orthopedic injuries. Everybody thinks about knees and ankles, but shoulders play a big part of that too. Give us kind of an overview of, kind of the age range and the kind of injuries that you see.
Yeah, so we see all kinds of shoulder stuff. Basically, the shoulder is one of the most common causes or sources of pain in human beings. In fact, uh, it affects more people in terms of age than really just about everything else that we see, truthfully. In the knee, for instance, you kind of have a connection with activity level, and there's a little bit more of a connection with organized sports and that kind of deal. But the shoulder affects people who are athletes, non-athletes. It affects people from ages 5 to 95 and up. So we see it all across the board, and from stuff that doesn't need surgery, most of it does not need surgery, all the way through stuff that really does need an operation to make better.
So before we get into the specific injuries and treatments, why don't you tell us a little bit about the shoulder anatomy?
Sure. So the shoulder, basically, the best way to think about the shoulder is it's like a golf ball on a tee. So it's just the golf ball sitting on the tee, and it has a ton of motion. So if I move my shoulder around here, I can move it in all kind of different directions, which is unique to the joints in the body. And it's because that ball of the bone of the golf ball on the tee has very little constraint. And what keeps it in the socket and keeps it positioned where it's supposed to be uh, are a lot of muscle forces and then the lining of the shoulder joint itself. So it's very malleable, and there are a lot of things that can impact kind of the way that it moves and the way that it feels, because it has to allow the arm to move in so many different positions. And so the basic anatomy of the shoulder in terms of the bones, you've got the ball, which is the humerus, that's the arm bone, and the socket, which is what's called the glenoid, which is part of the shoulder blade. And then you've got a lot of muscles around the shoulder which hold the ball in place. So the muscles you hear the most about are the rotator cuff muscles. And they're called that because they're a group of 4 different muscles which look kind of like a shirt cuff. It's sort of like this, the cuff on my sleeve here. As they go over top of the ball and hold it in position, it looks kind of like a shirt cuff. And then you've got a layer of muscles outside that. You've got the deltoid muscle, which is the one that lets you bring the arm out to the side. And you've got another bone that comes into play, the collarbone, the clavicle, comes in and joins the top of the shoulder blade at the top of the shoulder and forms a little joint called the AC joint. And then you've got the biceps muscle in the front, which is the one, of course, you do like bicep curls, you bring your arm up, that's the, you show your muscle. That's the muscle we talk about there. So you got muscles, bones, and a couple different joints interacting there to make up the whole thing.
A lot going on in the shoulder. So talk to us now about some of the basic injuries that you see. I think there's 5 of them that we want to talk about today, starting out with instability.
Yeah, so instability of the shoulder, that's a very common injury. It tends to affect athletes, patients, what have you, when they're a little bit younger in general. And the issue there is in part because the shoulder, it has so much movement. It has so much ability to get itself in different positions that it's a victim of its own strength. So because it has the ability to get in so many different positions and there is so little constraint on the joint, it gives it the opportunity actually to pop out of the socket. And once it pops out of the socket with an injury, it tends to stretch some of the mechanisms that normally keep the joint in position. And that can make it so it keeps popping out. So when people say I've got shoulder instability, what they're talking about is the shoulder dislocates, pops. What that means is it comes all the way out of the socket, and then it may pop in back on its own, or you may have to go to the emergency room to get it popped back in. But then over the course of life, going through other sporting activities, the shoulder is looser than it was before that initial injury event, and it just keeps popping out. And it can pop out the front or it can pop out the back. What's called an anterior shoulder dislocation, which is where the golf ball on the tee flips out the front. The front is in the front part as you're looking at somebody. That's the most common direction for it to go. But the issue is just that it keeps popping out, and that's a real problem for you to try to live your life. I mean, if your shoulder's dislocated, it's very painful, and it keeps you from doing a lot of activities. Here in North Carolina, actually, I have kind of a serious conversation with patients that have instability of the shoulder, because you don't necessarily have to get it fixed if you don't want to. But if you do activities that put you in a very precarious situation, or you would be in a very precarious situation if your shoulder dislocated, like whitewater kayaking or rafting or rock climbing, that kind of thing. And there's a fair amount of that here. Actually, I'll tell people, look, you really should not do that type of sport anymore unless you get this fixed, because you could die. If your shoulder dislocated doing something like that, it would be a really scary, dangerous type situation. But that's really what shoulder instability is. It's basically the golf ball coming off the tee one time, and then it continues to pop out over time. Now, that's the most common type of instability that we see. There's another type of instability that's not quite as common, that happens to go with people who haven't necessarily had an injury to make it too loose, but they're just sort of born really loose jointed. That's called multidirectional instability, which is a different thing. It's a common deal that we see in patients or in athletes that do sports involving a lot of throwing, overhead throwing sports, particularly when the shoulder's so loose jointed to begin with, it's more likely to shift, and they'll have symptoms from that. So there are ways we deal with those 2 different types of instability, and the treatment's actually really different. So if you have an injury that starts it off and you have the shoulder keeps popping out, the best way to fix that actually is with an operation. That's the one thing we found works really well. Nothing else really works great for that type of instability. If you've got a type of instability where the shoulder's just super loose jointed to begin with, and it just keeps shifting abnormally, that's something actually that physical therapy and strengthening exercises will do a really good job of making better. So we try to figure out when we see patients with instability symptoms, we try to figure out, first of all, is it coming from the shoulder itself? There are actually some other things that might cause that sense that the shoulder's not stable. But if it is coming from the shoulder, we try to put it in those two categories. Is it something that needs an operation or something that'll do well with just some exercises?
Okay, terrific. And there's two kinds, traumatic and atraumatic. Did you cover that?
Yeah, exactly. So that's the traumatic is the type. What that means is it happens with an injury. So the classic traumatic type of instability is someone who has a totally normal shoulder to begin with, and they're playing football and they get tackled and their shoulder gets forced out and it causes stretching of it's really the problem is in the lining of the joint. If it gets stretched, it then allows the shoulder to keep popping out over time. That type of instability is the one that really doesn't get better unless it has an operation to fix it. The other type, the atraumatic that you talked about, that just means not from an injury. And those are patients that are just super loose jointed to begin with. There's a test we'll do on those patients to see if they can, I'm super tight here. I'm not loose jointed at all. But if you can bend your thumb all the way back to your forearm, that's one of many signs we look for to see if you're just super loose jointed. Those types of patients usually don't need surgery at all, actually. Those are patients that can strengthen the muscles around the shoulder, and the muscles can start doing a better job of trying to hold that golf ball in the tee.
Okay, so how do you treat the traumatic injuries? What are the different ways that you would evaluate it and then treat it?
Well, the first thing you do if someone pops a shoulder out, you gotta put it back in the socket, actually. And that can be a little bit traumatic. You could do that. There are a lot of different ways you can do it. Probably the easiest way, and you're not going to see this a lot on a football field, because as soon as an athlete on the playing field actually dislocates their shoulder, we try to get them off the field and take them back to the training room or the locker room or someplace where there's not a ton of people watching, and we actually will have them lie on their stomach, and they hang their arm over the side of the table like this, and you put a little weight on their wrist, and you just let them lie there and relax. And actually, as the muscles relax, the shoulder usually will pop itself back in. Sometimes it takes a lot more than that, though. Occasionally, that doesn't work, and that's where we have to take the patient to the emergency room and sedate them so they're totally relaxed and asleep, and you pop it back in that situation. And there are some weird type of dislocations, really rare, where we have to take them to the operating room to do it. Vast majority of the time, we're able to just put it right back in where it happened. But that's the first thing we do is we get it back in place, and then we typically would get an X-ray to sort of get a sense for, is there any other type of bony injury? And usually it ends up involving getting an MRI as well to see if any of the soft tissue structures around the shoulder, the tendons and the what's called the labrum, which is the tissue that sits on the edge of the socket, if there are injuries to those structures. And then we come up with a treatment plan, depending on what type of instability we think is going on. So if in that case, that's the traumatic type, usually we're talking to patients about what to expect moving forward. And we've done a pretty good job in orthopedics figuring out with that type of instability, which patients are probably going to have issues with it moving forward. And it turns out it's really connected with age. So if you're the highest risk patient, if you've dislocated the shoulder, the highest risk for having it continue to pop out is if you're under 20, male athlete, and playing collision sports. Those three factors, there's almost 100% chance it'll keep popping out. But if you're over 30 and a female athlete, you don't do collision sports, chances are actually pretty low, probably 10% or less that you're going to have an issue with it. So we counsel patients about that. And we try to make sure that there's nothing else going on. But if it's just that one issue, we kind of make an assessment of what the risk of it coming up as a problem in the future is. And every patient's different, though. I mean, there's an acceptable level of what's called recurrence, of having it continue to be instable, continue to pop out over time. And for some athletes, it's acceptable, leave it alone, and we'll just watch it. For those where it's popping out a lot and it's really getting in the way of their lives, that's where we'd say, okay, look, maybe we need to fix this.
And then probably the most common question you get is when can I go back to play after an instability injury happens?
Yeah, we get it all the time. And the answer is, as long as there's not anything else going on, as long as there's not a broken bone or a torn tendon that might get worse. If it's just that the shoulder's popped out, then the answer is for most of us that specialize in these injuries, it actually is you can go back and play as soon as you have full range of motion and strength, provided you understand that there's a risk that it may pop out again, depending on those factors we talked about before. So if you're at high risk, I'd counsel a high school football player, for instance. I'd say, look, you can go back and play, but there's a pretty good chance this thing is going to pop out, probably better than 50% in this season. And that's something we keep an eye on. We don't really want people to get hurt. If they're a whitewater kayaker or a rock climber, I'd say I would not go back to that, because again, you get yourself killed if your shoulder dislocates. But if it's just your typical sport and nothing else is going on, you can go back within, usually it's a week or two once you get full motion and strength back. You just have to understand you got an injury that may come up as an issue moving forward.
What about the folks that are atraumatic? Do you treat them differently or give them a different timeline?
So that's a much different animal, and that's something that's not really causing harm to the shoulder. It's more just a reflection of how loose jointed that person is to begin with. And because that type of instability really didn't cause damage at all, those are patients where we'd say you can go back whenever you're comfortable. And it depends on how traumatic it was. Sometimes it's not just a physical trauma. If a shoulder really pops out of the socket, that can be kind of emotionally traumatic too. But if they feel up to going back out there and they want to do it, it's really whenever they feel comfortable. Those are patients, the atraumatic type, where we'd say, look, let's get you into a really good therapy program where you're doing good strengthening exercises with your trainer or your team, or just on your own, and then go back and continue doing those exercises as a warm-up for that sport. So you try to prevent it from happening again.
All right, terrific. Want to remind everybody to put your questions in the chat. At the end of this conversation, we'll be happy to have our providers answer your questions. Another kind of injury that can happen is called impingement. How does that present itself, and how does it happen?
So impingement is what that really means, Mike. That means pinching. And what impingement means, what that means in the shoulder is that as you raise your arm up over your head like this, the rotator cuff tendons get pinched on the roof of the shoulder. So if you feel the top of your shoulder, you'll feel there's like a bone there. And as you raise your arm up, that bone, what that is, that's part of your shoulder blade actually. And directly underneath it, the rotator cuff tendons sit. And so as you raise your arm up like this, those tendons get pinched up against that bone. Now, that's not a bad thing. That's supposed to happen. That's how your shoulder's built. But what impingement means is that if you have some imbalanced forces in the joint, when you raise the arm up like that, that pinching will hurt. And that really is the key part of this. Impingement, really what that is a reflection of, is a muscle imbalance. And you happen to feel, we get muscle imbalances all the time. The human body is one, we got a skeleton and we've got muscles and tendons outside the skeleton, which allow us to move around. Not all muscles work together pulling on one side of a joint versus the other in a way that's balanced. And especially as we go through life, those imbalances become more pronounced. So if you're a high school kid, those kids are made of rubber. They don't feel anything. But as you get into our age group, for sure, a lot of what we do during the day is what we're doing right now. We're sitting. And that's what most people do for the majority of the day. When you're not using the muscles around your shoulder as much as you normally would, or as much as the muscles would want to be used, some of them get a little weaker quicker than others do. And that creates an imbalance. So if you remember that anatomy of the shoulder, the golf ball and the tee, the muscles around the shoulder, largely the balance of those muscles pulling on one side or the other will dictate how much it may tilt or shift when it's in the joint. And if that imbalance is there, that shifting will put more pressure on some parts of the shoulder than others. In the shoulder, we feel it a lot. We happen to feel that type of imbalance in the shoulder more than anywhere else in the body, because the shoulder has so much movement and it depends so much on those muscles working correctly. When you get that imbalance, what happens is when you raise the arm up, the pinching on the rotator cuff is stronger than it would normally be, so it hurts. So really, when we say impingement, what we're talking about really, it's less of a pinching. I try to dispel this a little bit. It's not a great term. It's an older term that we came up with in orthopedics about 20, 30 years ago. And it suggests that the pinching is bad. It's not really bad. It doesn't really harm the tendon, at least not in the short term, but it causes pain. And the reason it hurts is because there's a muscle imbalance. And that's the reason that's how we treat it, is by it's not a surgical thing. You don't need surgery to fix that. You just have to fix the muscle imbalance. The impingement is so common. What I tell patients, actually, it's normal. Literally every person on the planet, if you live long enough, particularly those over age 30, you're going to have a little bit of this at some point. It basically is just pain on the upper outer part of the arm, usually when you raise the arm up over your head, but you'll also feel it when you're trying to lift things. And a lot of times you'll feel it at night when you sleep, because when you lie down at night, there's more force on that part of the shoulder where the rotator cuff goes up against the roof of the bone. So you'll feel it at night too. But it's so common, it's normal. It's the most common shoulder ailment in human beings, the most common thing we see patients for the shoulder. It's impingement. And it's an easy diagnosis, and it's easy to reassure patients, don't worry about this. Let's just get you in to see a physical therapist. Use your shoulder, don't not use it. Actually, sometimes I'll tell patients, look, you don't need to do anything to this if you don't want to. You've got a great, healthy shoulder. All you need to do is use it. And a lot of times we see patients, they get into this cycle where it hurts, so they don't use it. And that's just instinct, right? You don't want to harm anything. You don't use it. That makes it weaker, which makes it hurt more. So you use it less, which makes it weaker, which makes it hurt more. So you use it less, it gets weaker. It's a cycle. And so a lot of times I'll see patients that have had impingement for years, and they just need to know that it's okay to use it, and that they got to get back out there. And if they get back out there and do their thing and work out and exercise the way they want to, it often will go away.
That's pretty great. Talk about AC separations. First of all, what are they, and how do they happen?
So the AC joint is the joint where the collarbone comes into the end of the shoulder blade, what's called the acromion. So that what the AC stands for is acromioclavicular, which just means the joint of the collarbone to the shoulder blade. And an AC separation is an injury where that joint, the joint itself, gets sprained, or sometimes you can actually have more severe injuries where the joint gets completely disrupted or torn apart. So an AC separation just means, and that's what you'll hear people say. The older way to describe this was a separated shoulder. And it's not really the shoulder, actually. It's the joint just above the shoulder joint, which is where the clavicle, the collarbone, comes into the shoulder blade. But there are all different types of AC separations. The most common that we'll see are in patients that get hit from the side, or they fall off a bike or something like that, land on the side of their shoulder. And that's just a sprain. So on an X-ray, the joint looks totally normal, and they just got a little soreness on the top where the joint was sprained. On the other end of the spectrum, you can have what's called a grade 5 AC separation, which is where all the ligaments in the joint are torn. And that is kind of a funky looking injury, actually. That looks like the shoulder, it looks like the clavicle is sitting really high up and the shoulder is pulled all the way down. Because when that joint gets disrupted, actually the job of that joint is to keep the shoulder up. And so when you disrupt the joint, the shoulder kind of sinks down. And it looks really weird because it looks like it's really obvious. I mean, it's kind of a deforming looking injury because the collarbone's sitting really, really high up. And there are surgical options for fixing that if you have that bad of an injury. Most of the time, the most AC separations are just sprains. And we treat those with just some anti-inflammatory medicine, some physical therapy. Football players, for instance, that have that, collision athletes that have that, can go back and play as soon as they're comfortable enough to do it, because it's not causing harm. It just hurts.
Okay. Tell us about little leaguer shoulder. What's that all about?
So little leaguer shoulder is it's an injury of kids, throwing athletes, adolescent athletes in particular, who are usually, they're growing so fast, literally their arms are getting longer than their muscles can keep up with. And in that adolescent growth spurt phase, throwers in particular will put so much force through the shoulder that the muscles can't hold the force back. And the issue there is that the forces go through the path of least resistance. They're not going to go through bone when they can go through cartilage. So if you're an adolescent growing athlete that is going through a growth spurt, you got long arms and you're whipping the ball around, a million miles an hour, you can get an injury to the growth plate, which is the part of the bone that allows growth. And that growth plate is not made of bone, it's made of cartilage. And so you'll see that actually a little bit on an x-ray with athletes that have this, you'll see that growth plate, that band of cartilage. It looks to some people like it's a broken bone, but it's not. You just don't see it on an x-ray because cartilage is clear on an x-ray. It's not calcified. So it looks like a gap, but that gap gets wider. And what that reflects is just that the growth plate has been injured or irritated. And so it really is an overuse type injury. It does not need surgery. It does not cause any harm. It doesn't impair growth. So it is not harmful. It's a very, very common. It's basically just a reflection of the fact that athletes are growing and they're having a hard time their shoulders are having a hard time keeping up with them. The treatment for it is really just rest and some basic therapy exercises with their team, but avoiding throwing and high demand shoulder type sports until basically the shoulder can catch back up and the growth plate can heal itself.
What to that end, what can parents do and players do to kind of prevent this injury, or what should they watch out for to see it coming?
So it depends on the sport, really, but there sort of like two answers to that. The first is if a child or an athlete is doing a sport that is an overhead throwing sport, that's particularly demanding on the shoulder. So we recommend that those athletes be particularly careful about watching, for instance, in baseball, if you're a pitcher in particular, it's one of the highest demand overhead throwing sports that you limit how many pitches you do. So there are pitch counts that are done, and every pitcher out there in this day and age knows about that. And so you sort of kind of try to keep the activity reasonable. So that's one thing in terms of throwing sports. The other, just that applies to really all sports and all activities, is just to maintain that muscle balance. So just like in our age group, we get impingement because the muscles aren't balanced correctly in the shoulder. In younger athletes that have growth plates that are open and who are trying to keep up with their own growth, when they're doing these high intensity type sports, just keep the muscles balanced. And that can be more of a struggle than you might imagine. Some of these athletes are putting tremendous forces through their arms when they throw or when they lift or when they get tackled. It's something like 8 times body weight of force goes through the arm when you throw a pitch, which is, even if you're a small kid, let's say you weigh 100 pounds, that's 800 pounds going through your shoulder. It's amazing. So you got to have those muscles working well together. And that is a part of what preseason training is about, and what most of these teams sports that involve upper body use on an intensive basis, they do a lot of weight training and strength training before the season. So best way to prevent it or keep it from being an issue is to just keep the shoulder strong. And it's not just doing a lot of bench press. You got to make sure you balance things. So a good trainer and a good preseason strengthening program is going to work on all the muscles equally to keep them working together the way they need to. So that's the best way.
Okay, you just went over a few things that people can do to take care of their shoulders. For baseball players, especially those that are training year-round now, what are some other tips that you have for them to prevent injury and not to overuse their arm or their shoulder while they're training?
Yeah, so that gets back to really sort of just some of the fundamentals about training in general. You want to make sure you have enough recovery. The recovery, I tell my athletes, and from my former sports days, I remember as well, the recovery is as important, if not more important, than the actual training itself. So you've got to rest. When you're out there training intensely, you don't want to just be gunning it 100% of the time. You need to back off. Most of the training that's out there for the high demand cardiovascular sports stuff like triathlons and swimming and that sort of thing has figured out over the years this concept called periodic training, where you do a big cycle of high intensity stuff and you come back down and you rest. And other sports, ball sports like obviously football, basketball, baseball, softball, have also realized this, but it's a little bit harder to implement if you have like a season that's just really intense. You got a couple games every week. But it may be harder to pull back a little bit. You got to make sure you listen to your body. And when you get a little bit overtrained, you got to back off. One of the things I see in a lot of my athletes, and I know is true for me personally, when I was back a long, long time ago, when I was in sports, is you start feeling like you're dreading it, going to work out. That could be a sign you may be overtraining. And there are lots of ways you can monitor that sort of thing. But the easiest thing on the shoulder is if your shoulder starts to be sore and it's consistently sore. So I'll tell my throwing athletes, look, if your shoulder's sore after a workout on Monday, that's fine. Soreness is okay. But if that soreness doesn't go away after a day or two, you may be overdoing it. You may need to pull back a little bit and listen to that. It's your body saying it's trying to heal, but you got to give it an opportunity to do it.
Okay, very good. Dr. P, that's all that we have with you right now. We're going to talk to one of OrthoCarolina's physical therapists, bring you back in a few minutes to answer questions from our viewers. So thanks.
Sure. Happy to. Thanks, Mike.
We're about to show some exercises to work on activation of some of the important calf muscles. When we are raising up into the air, the shoulder needs to be able to drop down in the socket in order to not only sink it down and stabilize it, but also allow it to set in the correct position for overhead reaching or the majority of reaches to go throughout the day. Taking this band, throwing it over the top, any door. Nice thing if you get a long enough band is you provide a couple different resistances. With this band, we could use one for resistance. If we needed additional, we just add a second one in. First motion, starting down by your side. Everything is nice and relaxed. We don't want to see that shoulder right up at all. Coming out about 70, 80 degrees out. Doesn't need to be specific. And nice and slow, coming back down to the side. Slow and control is the key. We're not trying to rush anything. Small muscles, so we do not need a lot of resistance. Low resistance, low speed, high repetitions. That can be sets of 10, 20, 30, 2 or 3 cycles of that, whatever you would like. Nice and control coming down. Next exercise, the tricep is very important as well for not only assisting with keeping the ball back in the socket, but also sinking it down and stabilizing as well. Wrapping around, stabilizing. Once again, good posture. I like to tell a lot of people, imagine you've got a $100 bill right between your shoulder blades. You just want to grab that. You don't want to smash it. And then just nice and controlled down. Slow coming back. Everything's nice and relaxed. Pinch that $100 bill. Nice and slow. And relax. Same idea. 10, 20, 30 on the reps. Slow control, low resistance. Nice and easy. Another simple movement we can do, anytime we are raising up into the air, there is some external rotation motion which is occurring. So we need to work on improving the activation of those external rotator muscles to assist with overhead reaching. A simple way to do that, take a band. From here, relaxed, we can work on slightly pulling apart, grabbing that $100 bill, nice and slow. We can also combine that by pulling apart, reaching out, slow coming back. If you do this in front of a mirror, we want to make sure those shoulders stay nice and relaxed. We do not want to see this happen. A lot of times our upper trap muscle does too much work, and we want to make sure some of the lower trap muscles in the back are actually doing a little bit more work. So a quick review, you can combine these. You could do about 5 repetitions, easy coming out, and then you could hold that position and do 5 repetitions, reaching out. This is a fatiguing type of movement, especially when we combine these together. We're looking for a nice, controlled, solid movement, which looks nice and smooth if you're watching yourself in a mirror. Big key whenever you're doing any of these exercises, always find something that's eye level. As soon as that head tilts down, that thoracic spine goes with it. So if you're sitting in front of a computer all day long, you'll know exactly what I mean. A lot of people who may be golfers or other athletes, that same thing happens with our posture. As soon as that head comes down, we see a lot of people at the gyms working out here. Find something eye level. Imagine you've got that $100 bill right between your shoulder blades. That can help improve that posture We don't want this to happen. We want to let everything just stay nice and relaxed.
Quick question. If someone doesn't have access to these exact bands that you're using, are there any household items that would do the trick?
Household items are very difficult to replicate this. The nice thing, especially department stores, or everybody loves Amazon, these are called TheraBands or resistant band sets. You can get a very simple set of a couple bands for $10, $15, $20, and they're still available online even though COVID's going on and a lot of weights are unavailable. Resistance band sets are very, very inexpensive as far as purchase. You can also get something very simple like this at Dick's Sporting Goods. Sometimes you'd find these at a Walmart. Your easiest thing is obviously just order them online. And a lot of times if you do need any rehab or if you are seeing an orthopedic provider, some of them will provide these to you as well. So we do also have that option.
Excellent. Cool.
Next one, a couple of these we're going to do laying down. This is to start to work on activating some of the shoulder blade muscles. The reason why I do like to lay down a lot of times versus the old school way I kind of call it is people will do your rows, your extensions, kind of your lateral raises. The problem is gravity is bringing everything forward and we don't want that. It's a bad pattern, a bad kind of habit movement that we get into. So we can do some of these laying down and still accomplish the same task. Shoulders are relaxed, nice and controlled coming apart. Touch your chest, slow coming back up. Not going into pain, nice and controlled. Out and back. As you get to the bottom, you're slowly grabbing that $100 bill. Another motion you can do, taking that little loop, attach it to your foot. You can put a towel underneath the arm if you need, but we're rotating back. Nice and controlled. Working 2 of the 4 rotator cuff muscles here for stability and stabilization. A little bit more resistance, the foot can come out, or same idea, you could grab both bands if long enough. Next motion, arm is straight, shoulder is relaxed. You're gonna come up and nice and slow. Once again, we're doing these lying down so that upper trap, that big muscle that likes to cheat, stays nice and relaxed. Coming up. If you have pain, take an extra second, set those shoulder blades in the right position, see if your symptoms change. A small change in your setup can make a massive difference with regards to pain or no pain. Last exercise, take the band, attach it to your underneath of the shoulder blades. Arms are straight and you're imagining you're reaching up towards the ceiling. Slow coming down. Up. Slow coming down. We want one arm at a time. We may get a little bit of spinal motion, a little bit of rotation. But we're trying to do one arm at a time. That is perfectly okay. Need more resistance? Higher up on the band, or grab a harder band. These exercises are designed to activate the correct muscles, turn off the muscles which are doing too much, which may be contributing to possibly a tendonitis type of situation or bursitis situation. These may go towards some habitual or some kind of bad pattern movements which are occurring. Maybe it's because of work, because of an athletic event, because of something that has gone negatively because of COVID. Any of these reasons can be what is causing some of your symptoms to be present, which can be treated by either the physicians or the surgeons or the therapists on our end.
Aside from pain, are there any other indicators that someone might be performing an exercise incorrectly or red flags to look out for?
Not necessarily. Pain is really the big indicating factor whether a tissue is being stressed in a negative way. Everybody moves a little bit differently. We all walk a little bit differently. We all reach a little bit differently. Everybody has their own little bit of a pattern. So as long as we are as close as we can to the right direction of motion, I'm perfectly fine with people having a little bit of a tweak in their own way because it's not a negative thing as long as they're not having pain. As long as they're remembering to really keep the couple key factors of pinch that bill slightly between their shoulder blades, make sure that their shoulder's not raising up in the air and it's a nice relaxed position, and we're trying to take that limb or that arm through its full range of motion as often as we possibly can, so we're not just training right here because we don't just live in that motion throughout the day.
Got it. Also, you mentioned a few times about the trap and the trap really kind of overworking and leading to weaker shoulder muscles. Do you have any tips for kind of how to maybe release tension in the trap and keep the trap in its place, so to speak?
Yes, so a lot of times everybody likes to get massages. They think, go get massages, go relax that upper trap, let's go get all those knots out of there. Take an extra second and think about why are the knots there. A lot of times we get stiffness, we get restrictions mostly in the upper trap or in the neck area because of bad posture, stress at work, maybe you're driving a lot, maybe there's an injury involved. So the trapezius muscle itself, if we look at it on Google, for example, we have upper fibers, middle fibers, and lower fibers. They all have an important role to play. So if only the upper fibers is firing or doing too much of the work, then we're going to have a bad movement with regards to kind of our shoulders, which can affect not only chest, shoulder, neck, and we can kind of get into this bad position. And that also goes right along with our pec muscles as well, because we do like to tighten up through here and we tighten up through here just because of stress and just kind of bad posture in general. There's a lot of customization which can occur. A lot of the exercises that I like to review with patients kind of go on a phase 1, 2, 3 program. A lot of the exercises that people have success with regards to their symptoms typically occur with phase 1. And a lot of what we review today is a lot of the phase 1 exercises because it truly is just muscles that are not working the way they need to and they need to be activated correctly. So the other guys stop doing too much and the compensation stops occurring. So once an individual is able to master phase 1, then they're more than welcome to come back for another visit or further treatment to maybe get to phase 2 or phase 3, depending on what their goals are, whether that be somebody who is in athletics who's trying to get back to maybe pitching in a little league game, whether that's somebody who's just trying to be able to get back to work or just in general getting back to live their life without having pain because they need to take care of a family member or a child or something like that.
All right. Thank you, Mike. Thank you, Dr. P. We appreciate your time and answering and kind of going over some of those basics for us about shoulder injuries. Now it's the time to talk about your questions and your concerns. And so I want to bring Mike back in to talk about one of the questions that we saw in the chat was, why is it important to warm up the shoulders before any exercise, Mike?
Warm up is very important in any situation of the body because if the muscles are not warmed up correctly, kind of deviations or modifications of certain movements can occur, which can just cause things to not function correctly. In a nice cold winter, if you're in the north, you wouldn't really want to take your car and just go out, turn it on, and then take it down the highway as fast as you can. Things they break down in a quicker way than normal. So when things are warmed up, your body is more prepared to complete whatever task you want to throw at it. So whether it be a pitcher, whether it be a quarterback, something like that, you see a lot of times on the sidelines before games in the bullpen, a lot of the athletes are there warming up with their TheraBands, getting every muscle to be prepared for whatever task you're going to throw at it. And the more prepared the body is, the better outcome you're going to get.
All right. Dr. P, we've got a question for you. How soon should a growing baseball players, at what point should they start throwing other pitches other than a fastball?
Yeah, that's a good one, Mike. That's a can of worms, controversial kind of topic. There are a lot of different recommendations for that, and the honest answer is there's probably no perfect answer for every thrower. But usually, we like kids to be done the majority of their growth before they start really throwing curveballs and sliders and everything else, because what really happens in adolescence, one of the things that we talked about before was these kids literally are growing faster than their bodies can keep up with. They can't keep up with the length of their arms, literally, and their back and legs and everything are growing too fast for them. And you start adding in these pitches, which put tremendous force on the elbow, and it does increase the risk of injury at some level. And then the question is how much is that risk, and can some throwers handle it while others may not? Sure, there are lots of variables there, but usually adolescent throwers, we usually recommend trying to stay away from those pitches on a regular basis. And it probably is not until the late teens, end of high school kind of time frame when it's probably truly not that big of a deal. But the answer is really athlete specific. And so for athletes, for throwers that have really good mechanics and have really built up a lot of the core strength and a lot of the things that Mike was talking about, it's okay to do it likely sooner than that. But it probably has as much to do with age and maturity as it does with their balance and how well they've maintained their strength throughout their careers to date.
Okay. Another question came in is, what's the difference between bursitis and tendonitis?
Yeah, great question. So that just gets back to your Latin. I don't know if anyone out there has taken Latin. I did not take Latin. But most of medical terminology has some Latin roots. And so itis on that word means inflammation. And so the difference is what tissue is inflamed. So a bursa versus a tendon. So tendonitis is inflammation of a tendon. Bursitis is inflammation of a bursa. A bursa is basically, you hear that all the time. Oh, I got bursitis here and there. A bursa is it's a fluid-filled sac. So if you take like a Ziploc bag in your kitchen, you put a little bit of water in it, and you seal it, and you rub the edges of the bag together, that's super slippery. And that's what a bursa is. That's the mechanism that your body uses all over it to lubricate the interface between things that are rubbing against each other. So a lot of tendons will actually have a bursal sac on top of them as they move to lubricate that interface. So you can have inflammation of that sac. The most common place that people get bursitis is at the tip of their elbow, by the way. If you sort of rub your elbow like this, the skin will glide over top of the bone because there's a little bursal sac in there. And so you can get bursitis of that if it gets irritated or inflamed. That's bursitis. Tendonitis is just where the tendon is just the attachment of a muscle to bone. That attachment can get irritated too. So it's a difference in what tissue we're talking about.
All right. Mike, you showed us a number of exercises earlier, and a question came in is, how often should somebody do those exercises? And then as far as sets go, how much should they repeat them?
Dr. P touched on this earlier about anytime you are doing any exercises, whether they be workout or whether they be a sport, making sure that you recover. So normally I'll tell individuals, if you can knock them out at least 3 or 4 times a week, I'm happy with that. I understand that people get busy. So really making sure that you have a good workout session, have a day off, another good workout session, or you can put back-to-back days in and just make sure that third day that you're really looking at, how do I feel? Am I fully recovered? Am I sore? Is my body telling me to take some time off? As far as repetition and sets, anytime you can look at trying to fatigue muscles. The exercises that we reviewed are not high intensity power muscles. They're not going to build the muscles that you're going to see that people are trying to develop. You're going to the beach for the weekend. So the muscles we're looking at are stability, kind of endurance muscles. So we want to look at starting out maybe 10 or 15 reps, 2-3 sets. If you're able to build up, normally I tell people if you can get to 30 repetitions in 3 sets, that's a good time to increase your resistance, and then you drop your repetitions down. When your repetitions go up, your resistance does not. But when you do increase your resistance, whether that be a higher level on the resistance band or whether that be a higher number on the weight, you do want to bring your repetitions down so that way you're not adjusting two things at one time.
Yeah, another question for you, Mike. How can young pitchers and pitchers in general prevent a slap tear?
How to prevent a slap tear? Really, by making sure all the muscles are stabilizing and working correctly. The throwers in general, as Dr. P touched on earlier, there is a lot of force that is going in multiple directions at one time whenever we are throwing. Throwing is one of the most challenging three-dimensional movements that you can put through the body because you are dealing with such small bony structures and a lot of contractile structures around there, dealing with the muscles to have to hold one piece in connection with another. So to prevent a slap tear is, in my opinion, like trying to prevent a rotator cuff tear and other issues in terms of making sure that all of the little muscles are doing their job and all of the big muscles are not overworking. So the rotator cuff muscles need to be very, very strong and need to be able to withstand all of the forces that you're putting through it. And not only just for one or two throws, but 20, 30, 40, 50, maybe 100 throws, depending on what the sport is, what in what position the individual is playing in. So really making sure that shoulder is strong and stable and nice and sound.
All right. Dr. Piasecki, a question came in about, is there such a thing as arthritis in the shoulder?
Yeah, definitely. Arthritis can happen in any joint. The shoulder's no different, but the good thing about shoulder arthritis is it usually doesn't bother people as much as knee or hip arthritis because we don't walk on our hands. The shoulder's not a weight-bearing joint, so you actually can get away with quite a bit of wear and tear of the shoulder joint without having a whole lot of symptoms. But the answer is yes, you definitely can. The shoulder joint, basically, it's that golf ball on a tee structure we talked about before, where the shoulder rotates around like this. And the humerus bone and the blade, the scapula, they come together, and where those two bones come together, there's cartilage that lubricates that joint, just like in the rest of your body. And if that cartilage gets worn out, you'll have some arthritis. But again, it is an issue for a lot of people. A lot of people out there have painful shoulder arthritis, but having a little bit of that usually doesn't amount to nearly as much as it.
Yeah, and another question there, if you dislocate your shoulder, is it okay to pop it back in without seeing a doctor?
Yeah. Well, the answer is yeah, you can if you know how to do it. You know, a lot of times, Mike, the shoulder will pop back in on its own. And if you're in the middle of the woods or something, if it's going to go back in, let it. Don't keep it from. Don't stop it. Let it go back in. And but the issue really is not just it's got to get back in place, but there's this collateral damage that happens too. You get the stretch and tearing of the rim of the socket and everything we talked about before. If you get up to Magowski, there's too young for it, but you and I are in an age group where if we dislocated our shoulders, there's a pretty good chance we tear our rotator cuff tendons, which is a much bigger deal. So the answer is yeah, you sure can if you know how to do it. But if it doesn't pop in on its own pretty quickly, it's probably not going to be doable or comfortable enough for you to do it yourself. And you're really going to end up wanting to see a doctor anyway to make sure that collateral damage hasn't occurred and to know what to do with that. So in all practical circumstances, you don't want to do a Mel Gibson on Lethal Weapon and try to, whack it back in on your own. If it's going to go in on its own, it's going to do it. If not, just go see a doctor. Let us help you with it.
Yeah, and then from there, how would you know if you needed to have surgery on that shoulder?
Well, it sort of depends on what the after effects are. There are some patients that shoulder pops out and they can't get it back in. So sometimes it's rare, but sometimes you need surgery to put it back in place. If you're a younger athlete that pops the shoulder out, usually the issue is sort of what we touched on before, where it feels better pretty quickly, but then it keeps popping out later in life. So if it pops out all the time, like particularly athletes that are up in this position, throwing, blocking a pass or something in football or getting a block shot in basketball, if it pops out like once a week or something, you can't really live well that way. So that's a time where you'd say, look, we got to fix this. And in our age group, if you pop it out and you tear the rotator cuff, well, then you got a pretty painful shoulder that's weak. And so that may be something that needs surgery too.
Yeah. Question for you, Mike. If a football player separates the AC joint or has an AC separation, how soon can they return to play?
Well, it all depends on the severity. That's where I would lean on our colleague here, Dr. Pisecki, to make sure that nothing else structurally is going on. The biggest concern right off the bat is when you have an AC separation is how bad is the separation? What grade are we giving that? And that's all handled by the medical side, Dr. P and his physician assistant. And really from there, you make the determination after that of, is there pain with movement? If there is, then we need to fix the movement. Whether that be getting range of motion back, making sure that motion is smooth and it's controlled, and then from there, making sure that the correct muscles are doing their work, and then making sure that we're actually reviewing the motions that individual needs to get back to. If it's quarterback, then obviously we're going to have them throw in the clinic. Maybe we need to fix some mechanics and some changes need to occur. Hopefully that's not the case, but really looking at what position are they playing, what sport are they playing, what movements do they need, are they able to obtain those flexibility and range of motion requirements, and then make sure they're ready to go, so that way they don't have any problems moving down the road. It's possible with just a grade 1, maybe grade 2 AC separation that this is a short-term issue, and long-term they never have any problems again because there's nothing structurally wrong other than just the bones have shifted slightly. But that's where we lean on the team effort to make sure on the medical side that everything big has been ruled out, and then we do our part to kind of clean up the rest and make sure they're ready to go back.
All right. Dr. P, another question for you. Is it possible to have a shoulder injury that causes internal pain that doesn't seem to diminish, but it never really shows up on an X-ray or an MRI?
Oh yeah, for sure, Mike. Actually, couple dimensions to that really. I mean, most of the shoulder pain that we see, whether it's from an injury or not, and I'll just tell you, of the patients I see in the office, probably 90% are in this category when it comes to the shoulder. They'll either have a normal MRI or a normal and a normal X-ray, or they'll have something abnormal on the MRI and X-ray that doesn't have anything to do with their pain. Most of the pain that we see is really in Migalski's court there, where you've got really, it's that, what you asked me about before, just inflammation, bursitis or tendinitis that really comes from a muscle imbalance. And that is not something that comes from a tear necessarily. Although I see a lot of patients that end up getting an MRI that has a tear seen on there, in quotes, tear. Which I think of more as like fraying. A lot of us have fraying in our shoulders. Most of us have fraying in our shoulders, actually, and it's quite normal. And so if you have pain, most of the time, statistically speaking, of course, there are a lot of people who have injuries that are more serious. But by the numbers, most of the time, shoulder pain does not come from a tear. It comes from just a muscle imbalance and inflammation. And so absolutely, I think, but most of the pain we see is in that category, actually. And you get an MRI, and either it's totally normal or it shows something that's not necessarily normal, but isn't causing a problem. You don't need to worry about it.
Okay. Mike, a question for you. If you've got popping and cracking in your shoulders, does that mean anything just with everyday use?
This is probably one of the most difficult things for any medical provider. I'm not going to speak for Dr. P completely, but we probably see this every single day with a large percentage of our evaluations and first-time visits to the PT world and medical side. Popping and cracking can be a couple different things. It could be possibly some arthritis. It could be some scar tissue. It could be some true laxity within the joint, that something is rolling over something else because maybe there is a little bit of increased flexibility within a joint from the front or the anterior instability or multi-directional instability. It could also be really nothing at all. We have pressure inside of our joints and we have pressure in the atmosphere. Anytime we cause a change in that pressure, we can cause a pop or a crack. No different than somebody popping and cracking their fingers or popping and cracking their neck. So it's possible that we're just causing a shift within the pressure inside of the shoulder itself, which could be causing that popping. A lot of times we don't look at the pop or the crack with certain movements. We look at what might be causing the popping and cracking. So the hardest part about therapy is I want to make sure that your shoulder is working correctly. It can only really work one way in terms of the way the mechanics function. So something completely unrelated to the popping and cracking, for example, your shoulder blade might not be moving correctly, but it's actually causing your shoulder to pop or crack. So we're going to look at the entire system, make sure everything is working correctly to try to fix that popping and cracking that's occurring. But a lot of times we have so much water in our bones and so much water in our joints that the popping and cracking, it really could be coming from anywhere. You may think you know where it's coming from, but it might be coming from a different spot that we're trying to figure out.
Okay. Dr. P, a question? Yeah, go ahead.
Well, I was just going to chime in there. I totally agree with that. I think the most common thing that we'll see patients for after tendonitis and bursitis, which we just talked about, is popping in the joint. And it sounds terrible. It's, I joke with my patients, I can pretty much wake up the entire house walking down the stairs, and I get up before everybody does and I go to sleep after everyone goes to bed. And it's, it's like a machine gun going off when I go up and down the stairs. And that is a normal part of the human body, and nobody really talks about it. And if you haven't had it before, and then all of a sudden, you hit your 30s and into your 40s, and you're like, I didn't hear this the other day. This sounds really alarming to me. You're not alone. Trust me. A lot of people feel that way. But we're here to tell you, don't worry about that. If it's not associated with pain or swelling, it's almost definitely not a big deal. If you're worried about it, come in, we can take a look at it. Mike's absolutely right. We try to make sure things are working well, but the majority of the time we can reassure you that it's not that big of a deal. And it does, the old wives' tale I used to hear when I was a kid, my grandmother would say, don't crack your knuckles, it's going to cause arthritis. No evidence of that at all. So you can crack away and don't stress about that.
Okay. And then another really common question is, once you dislocate your shoulder, how likely is it to happen again? And then I want to hear from both of you about prevention or things that you can do to strengthen that shoulder so that it doesn't get worse. So Dr. P, you want to go first?
Sure. So the answer, Mike, is it depends. And this is something my kids get on me about all the time too. The answer to pretty much every question is it depends, right? So a couple things we've learned about that in a study of shoulder instability that we've done, we've studied this for 50, 60 years, is that if you're in the category of patients that are just loose jointed, you're just super flexible, and it's just super, like you're going to be, the elastic person. You can do a split easy, you're just super flexible. That type of instability, when the shoulder pops out, when it's even maybe not from an injury, you're just so loose jointed that it comes out like that. That is something that usually does not end up needing surgery, and the likelihood it's going to come out again has mostly to do with the muscles and how they function around the shoulder. So that's what we call that multi-directional instability, type of instability. And that's something in terms of prevention. You see Migowski and his crew, and they're going to strengthen the shoulder, and probably 80 to 90% of the time it's going to prevent it from continuing to pop out. Now, the other type of instability that we see a lot of too is the shoulder that's in an athlete that isn't particularly loose jointed, and their shoulder is totally normal, and then they get hit and they have a contact type injury, or some type of a violent injury that forces the shoulder out of the socket. That type of instability, we can predict pretty well how likely it is it's going to come back based on how old you are, whether you're a boy or a girl, and the type of sports that you do. And so the younger you are, and male athletes, for whatever reason, we see it more commonly in collision sports. That's the highest risk category. So if you're an 18-year-old football player, male football player, and you pop the shoulder out, actually there's about a 90+% chance, even 100% in some studies, that the shoulder will continue to dislocate over time. But if you're in your 30s and you're a female triathlete and you don't do collision sports, the likelihood is less than 10%. And so we can predict that based on patient factors. And those are predictive factors. I personally don't believe even in the highest risk group that you're obligated to treat that. But that type of predictive value, we have that knowledge out there. And in terms of preventing it from happening, unfortunately for that type of instability, what we've learned is that not a whole lot helps prevent it from popping out again, except for surgery. And so if you're in that high risk group, we found that we can very predictably stop it from popping out with an operation. But unfortunately, wearing a sling or having an injection and even doing a whole lot of therapy, unfortunately, seems like it doesn't help very much.
Okay. Mike, what advice do you have for people to help prevent shoulder dislocations?
Dr. P touched on the biggest thing having to do with which group you're in. Those high risk individuals, as he said, are very difficult to manage because they are just simply at a higher likelihood of having another problem. The low to moderate group, really, a lot of times I'm talking with patients, I just say your chances decrease if you're able to diligently do your work and do your exercises. I cannot make the guarantee or make sure it's going to be perfect, but a lot of times when we do have a dislocation, we cause just a slight, not necessarily paralysis, but a slight turn off of some of the key cuff muscles. Where they take a step back and they need to be restarted and rebooted. And that's a lot of times what we focus on with the therapy exercises is take that step back. Let's get those muscles to turn on. Let's get them to do their job. And then let's get them stronger and better than they were before your injury, which will actually help possibly this problem occurring again. The biggest factor is what caused it. Was it traumatic? Was it non-traumatic? Was something else involved? But really, what group are you in? Are you in the low, the moderate, or the high risk group? And as long as you're in that low or that moderate group, as long as you do your exercises, which is really where people fall off. They feel good in a week or two. They just kind of ignore things. They just kind of ride into the sunset and think things are going to be just better. And a lot of times with therapy, we're not just fixing the problem, but really we want to focus on preventing it from coming back. And we try to prevent things as much as we possibly can. And really, any therapist who's not working on the prevention side of things is kind of not fulfilling their full duty in life.
All right. Thank you, fellas. Great insights tonight from our providers, Dana Piasecki and Mike Magowski from Ortho Carolina. We tried to answer a few of your questions. If we weren't able to do that, please engage the professionals at Ortho Carolina to help you out. That'll do it for Inside the Training Room this week. Thank you for joining us, and we will see you all next time. Thank you.
Thanks, Mike.